really important session where we'll be taking a deep dive into how cancer is currently affecting Kerala. We will explore the latest statistics, understand about developing trends, and even discuss some future predictions. The aim is to give us all a thorough understanding of the cancer burden right here in our state, with a particular emphasis on how prepared we are and what strategies we need to implement for better cancer control moving forward. To lead us through this crucial discussion, I would like to invite the session coordinators, Dr. Sunu Siriak and Dr. Gayatri Gopan, to introduce our esteemed moderator and panelist for the session.
Good morning, everyone. So, I welcome all gathered here to the capital city. Here in this platform, as we all know, we have so many specialist policy makers and thinkers, and we aim to discuss the problems revolving cancer care. So the conclave begins with the session on the cancer burden in Kerala, and the first topic is the state of Kerala, the cancer landscape. And we hope this session will explore the current epidemiology of cancer in Kerala, along with emerging trends and projections, as well as the preparedness on cancer and the future strategies for cancer control. To moderate this important session, we are privileged to have Dr. Prashant Mathur, who is the Director of ICMR, National Center for Disease Informatics and Research in Bangalore, and also a member of the Scientific Council of the International Agency for Research on Cancer. We welcome you, sir. Joining Dr. Prashant Mathur, we have eminent personalities in this field to contribute to this topic and to put forth their views based on their immense experience. We invite the session speakers, and all are exceptional in their respective fields. Padma Bhushan, Dr. S.H. Advani, sir. Sir is the Chief of Medical Oncology at multiple prominent hospitals, including Shushruth, Jaslok, Nanavati, SL Raheja, and HN Reliance. He is also recognized with Padma Bhushan, India's third highest civilian award. He is probably the first medical oncologist in the country who has witnessed the growth of medical oncology in India right from its birth. We welcome you, sir.
Now we should have had Dr. S.S. Lal with us, but unfortunately, because of some personal issues, he couldn't attend the meeting. May I welcome Dr. V. Ramangutti, who is a public health researcher and is currently the research director at Amala Institute of Medical Sciences. He was formerly a professor at the Achyutha Center, and he holds various degrees in pediatrics as well as public health from Harvard and applied economics from JNU. Welcome you, sir. May I welcome Dr. Narayanankutti Warrior, who is very familiar in the oncology circles, and he is the medical director of MVR Cancer Research Center at Calicut, and he is a recipient of several awards, including when he was awarded the award by ASCO as one of the 12 world leaders in oncology in 2018. He has also received the CH Center State Award and the MSF State Award. Welcome you, sir. May I welcome Professor Eliama Matthew, who is a cancer epidemiologist associated with Regional Cancer Center. Madam is well known in the cancer epidemiology circles across the country, and she has got more than 30 years of experience in cancer epidemiology and has seen the growth of the Indian cancer registries right from its birth. Welcome you, madam. With these few words of introduction, we wish to hand over the podium to Professor Prashant Mathur for further deliberation on the topic. Thank you.
Good morning, everyone. It's a privilege and honor to kickstart a very important conclave on cancer in the perspective of Kerala state. The state has demonstrated several leadership roles in the past, and this will certainly be another leadership role in the area of cancer prevention and control, which the group will take forward. And I wish to congratulate the organizers for identifying such a conclave, bringing it forth, and inviting multiple stakeholders, multidisciplinary approach, which actually would truly be able to tackle the menace of cancer. So the way we have planned this session, I would present a few slides to put some things in perspective, not a detailed on cancer epidemiology, but just leave some thoughts to start thinking, and also then invite our esteemed panelists to give their interventions around cancer, cancer epidemiology, what they observe, what they experienced, and what they feel about it. Then we would take some questions from the participants and then wrap up the session so that we are well in time. So can I have the presentation on the screen? So I come from the Indian Council of Medical Research, National Center for Disease Informatics and Research in Bangalore. And many of you know that we have been running the National Cancer Registry Program, which is the only disease registry in India which is working since 44 years. And there are stalwarts here, like Professor Advani, who must have seen the nurturing of this registry. And this has grown organically over the decades, and yet it has to grow much more. Currently, we cover 18% of the Indian population, and a major limitation is that cancer is not a notified disease in India, unlike other developed countries. Though there are 17 states now who have notified cancer as a notified disease, and Kerala is one of them. So unless and until there is good coverage, good representativeness of the data, we can always question the reliability of data. But this is the best we have. And to check that we are doing a good job, we follow the standards laid down by the International Agency for Research on Cancer. And in the last CI5 volume, 19 registries qualified for inclusion into that. So it's a global database out of which Globocan is born. So I think creating this awareness about NCRP is equally important so that people quote NCRP. Because what you quote from Globocan for India is actually re-quoting NCRP. So it's like a repackaging which is done. So currently we run 37 population-based cancer registries in the country and 337 hospital-based cancer registries. And this is the network. So on your left, you can see the population-based cancer registries where they are located, and we have three in Kerala. But there are still some states where we are not present, like Rajasthan, Odisha, etc. But in terms of hospital-based cancer registries, we are present every nook and corner of the country. And we have other data linkages also now. For the last 2 years, we are receiving data from the Ayushman Bharat, the Tamil Nadu state cancer registries, and currently we are running 2 registries with the state of Himachal Pradesh and Andhra. We just completed Rajasthan. So as more and more states set up their own state cancer registries and start contributing to the NCRP, this will get enriched over the years. So what does NCRP give? It gives epidemiological insights into various aspects of cancer. So it is of interest for public health people, it is of interest to epidemiologists, it is of interest to clinicians, to policymakers, and you can mix all of them. So as I said, in Kerala we have 3 population-based cancer registries, Kollam, Thiruvananthapuram and Malabar, and 16 hospital-based cancer registries, which includes private sector also as well as the public sector. Now, this is our latest incidence rate, age-adjusted incidence rates across 43 population-based registries. This includes 9 population-based registries run by the Tata Memorial Center. And I don't know whether you can see each one of them. So this is the males, these are the females, and their age-adjusted incidence rates. So a publication should come out very soon in JAMA, maybe by the end of July. So the bracketed red ones are the 3 population-based registries of Kerala. And where do we stand? As Kerala, we stand higher up in the pedestal of incidence rates for both men and women. If you compare the status in Kerala versus the rest of the country, per 100,000 for all ages for the year 2024, the age-adjusted rate for all India comes to 105 per 100,000 for men and 103 for women, whereas in Kerala it is 243 and 219. Even the crude rates are much higher, so it's double the rate what the rest of India is experiencing. What are the relative proportion of cancer sites which are there in Kerala? For males and females, lung cancer with 14% contribution, oral cavity, colorectum, prostate, liver, and others, whereas for females, breast cancer continues to rule with 34% contribution, followed by thyroid cancer, colorectal, corpus uteri, ovary, and others. If you compare the incidence rates for some selected sites for Kerala and with the rest of the country, so the green bar is for Kerala, you can observe a very high incidence rates differences between Kerala for sites of lung, prostate, liver, and stomach. Though for mouth it is less in males. In females, breast cancer, thyroid cancer is very peculiar, but a lower rate for cervical cancer. What has changed in the last 10 to 15 years for females? 2006, 2008, and compared to 2015 to 19, these are the ranking of the top 10 sites of cancer. We observed a decrease in the mouth, cervical, and tongue cancers, but an increase in thyroid cancer, corpus uteri, colon, and non-Hodgkin's lymphoma. For men, there is an observed decrease in the ranking for stomach, laryngeal cancer, mouth, and esophageal cancer, but a rise in liver, prostate, rectum, and colon cancer. This is, we calculate the annual percentage for each site of cancer. That means this is the rate at which it is increasing. The red bars, everything is positively increasing. So if you look at for men and women, liver cancer, both sexes is rising rapidly from 9.8% to 11% annual percentage increase, and so on and so forth. So it is the rate at which a cancer incidence rises is something which we should pick up. The registry had been picking up rising thyroid cancers over the last 2 decades. And today it has come to occupy number 2 position in women especially. So what is the projections for Kerala for the year 2030? If things go on as such, then we are likely to see more cases in 2030. What is the crude mortality rate for cancer sites, selected cancer sites? Again, the green bar is for Kerala and the other is for all India. There are higher mortality rates being reported. If you look at the disability adjusted life years as a matrix of burden of cancer, For all sites, Kerala experiences a higher DALYs than the rest of India, and we have depicted some of the DALYs for individual sites. Then from our hospital data in Kerala, we looked at clinical extent of disease at diagnosis before treatment. And we picked up some sites to look at localized, locoregional, distant metastasis for lung, prostate, mouth, breast, ovary, and cervix uteri. There is still a lot of locally advanced and metastatic cancers being reported if you compare this to all India figures. So this calls for a higher effort for early diagnosis of cancer and to bring down the staging of cancer. So putting people, not only diagnosing them, but putting them on treatment efficiently and completing the treatment is equally important as a step for cancer prevention and taking it through the control. This, we have published papers on the 3 cancers, breast, cervix, and oral cancers. So comparing Kollam, Thiruvananthapuram versus the pooled India rates for the age-specific relative survival, Kerala is not doing bad in survival. This is 5-year survival, reflecting that the quality of care is perhaps better. And this is what we see if you look at the IARC SurfCan survival reports. Countries which have advanced cancers, but they still have a better survival than those countries without good quality of care. So I will leave at this point, and thank you for your kind attention. And I would now like to call upon our esteemed panelists to give their views. So I would start with Professor Advani, please, sir. If you could give your reflections on the cancer burden in Kerala.
Yeah, good morning. I think as it has been beautifully depicted that how different is the Kerala in terms of the statistics is really different. And as the rates are also, as mentioned, that they are really high number of the patients that you see. I have spent most of my time in Bombay, Western India, and now for last few years I have been regularly visiting Kerala, and I can see the difference, very clear-cut difference, I can tell you that. Sitting in the clinic, you don't have to look at the statistics, it's so obvious. One which is very clear, that in females, the breast cancer is on tremendously more than what we see in other parts of the country. Second thing which is important is the thyroid cancer. I've never seen so many thyroid cancer, what we see over here. In a small hospital at the periphery, Tier 2 city, we do almost 3 to 4 thyroid surgeries every week. I was surprised. I say, how do you get so many thyroid cancer over here? But that's true. The thyroid cancer is so common. And while in Bombay we also get the thyroid cancer, but the numbers are very small, really small. You ask the surgeons, they will tell you hardly any they are operating the thyroid cancer. So in females, these are the 2 important things that I have noticed. Of course, as mentioned, cervix cancer is very low in Kerala. In the males, what is happening in the males? One thing which was again clear-cut, that in males, the mouth cancer, which is rampant in Maharashtra or on that side, is relatively not that much high over here. So mouth cancer is, and probably related to the way the people in Maharashtra take lot of tobacco and pan and all. But the second most important thing is, every day I see the patients with the cirrhosis of liver and hepatocellular carcinoma. I thought that it's a mines of the hepatocellular carcinoma over here. It's just that I think one gets really surprised at how cirrhosis is common, as well as the hepatocellular carcinoma is so common, and it's not related to the hepatitis B or C. It's just non-viral cirrhosis of liver, and then maybe alcohol. Alcohol is one of the things which everybody enjoys in the Kerala. So I feel these are the things which are very obvious. Sitting in the outpatient, you can make it out a real big difference.
Yeah, thank you very much, sir. Can I invite Dr. Warrior, please?
Yeah, thank you. Thank you so much for this invitation. Basically, what Advani sir has said is very true in our practice. As an oncologist who is being working in this state for the last 25 years, what I observed is there is a very high incidence of diabetes. So diabetes is something which is driving all the lifestyle disease, and that is the reason why what you have said is very true, sir. Like along with the alcohol, the diabetes induced the liver disease, leading to cirrhosis and very high incidence of liver cancer. And one important difference I have noticed in case of lung cancer, because everybody talks about lung cancer. Lung cancer is always has been the major cancer in males. But the adenocarcinoma, the type of the carcinoma which we come across is adenocarcinoma, and it goes very along with what is reported in the Western population. So that difference is always there. We generally we don't see much squamous cell carcinoma here. And again, when coming to the breast cancer, we see about 300-fold increase in case of breast cancer for the last 25 years. One of the reasons mentioned is the postponing pregnancy in the first pregnancy beyond 30 years among our ladies, especially. All are very educated and they are all very ambitious, and taking employment is their priority, and then subsequently they want to do a project before going for first pregnancy. So these are some of the social factors which are totally different from the rest of India. And when it comes to the tobacco related, I feel that we do have a lot of tobacco, the smokers, but the incidence of oral cavity or the chewing, tobacco chewing has come down very drastically. But we are, of late, we are seeing a surge in the oral cavity cancers, which is going to be to make a comeback. The reason being, we entertain a lot of outside Kerala for labor, and or we have a lot of laborers who are coming from outside. So they mingle with the locals, and they again making others eat a lot of tobacco or the chewy tobacco. So that is one of the reasons why we see a lot of youngsters coming with oral cavity cancers, though the number is not very high right now. Then the pancreatic cancers again is also coming up more. I don't know, already in North India there is a very large population of hepatocellular, the hepatobiliary cancers. So I don't know what is the impact, but we see a lot of intrahepatic cholangiocarcinomas. If you look at the type of intrahepatic cholangiocarcinomas reported in the literature, the type of the cholangiocarcinomas are all hilar cholangiocarcinomas, but we see 80% of our cholangiocarcinomas are intrahepatic. I don't know what is the reason for that. And one more thing about the uterine cancer, we have a large population of uterine cancer, though we have put our interventions very cleverly and very effectively, so that our incidence of cervical cancers have gone down definitely. But we see a surge in the endometrial cancers and the uterine cancer, and probably in future, very soon, we see the endometrial cancers taking over cervical cancers in Kerala. Then about the colorectal cancers, there's a lot of influence on the food habit. Our consumption of fiber per person is very low compared to the national average as well as the national average. So we see a lot of colorectal cancers as well. And that is the reason why we see colorectal cancer has come up as the second most common cancer here. So these are my thoughts about the incident.
Thank you very much. I'll go to Dr. Eliama to finish the epi part of it, and I'll come back to you, sir. Dr. Eliama, please.
Good morning, everybody. At the outset, I thank organizers for inviting me to be a panelist. I'm very glad to be here. So I have been working in the cancer registry for the last more than 30 years. I will share my experience and where we need the target for cancer control. So as Prashant Mathu sir already provided the cancer pattern, and you have seen that Kerala comes in 5th or 6th position when we see the cancer rates. Those rates are age standardized rates. So, but when we see our burden can be expressed in terms of crude rate. Our crude rates are above 200 per 100,000 population. So there comes a burden. If the burden is so high, so that which indicates that that is mainly because of our older age population. Our more than 60 year, it is about 12% compared to, whereas when we see the national figures, it is about 6%. So that is the reason our burden of cancer is really high. It is now recent figures, when we see the recent figures, burden in Pathanamthitta district, it is nearly more than 300 per 100,000 women. So, and older age population is high. So the corresponding cancers like prostate cancer is high, and then lung cancer, in fact, the first common cancer, lung cancer, and the second is prostate cancer, and the third is colorectal cancers. And among women, you know that it is breast cancer is the commonest cancer, and already mentioned that thyroid cancer in South Kerala, thyroid is the commonest cancer, and in South, in fact, cervix uterine is the commonest cancer. Ovarian cancer, corpus uterine cancers are the commonest cancers. So then when we see the transition of cancers, of course, cervix uterine cancer on the decline, breast cancer is on the increase, and the annual % change is much higher compared to other parts of the country. So maybe detection, maybe improved methodology, but still it is on the rise. And of course, thyroid cancer, fortunately it is a better prognosis, so it is also on the rise. Especially in coastal areas, we have observed that in coastal areas, thyroid cancer is quite common, which is not in northern part of, thyroid cancer is not common in northern part of Kerala. Then the third cancer, colorectal cancer is also, the colorectal corpus uterine cancers are also on the rise. Of course, epithelial ovarian cancers are also on the rise. So most of the cancers except mouth cancer, esophageal cancers, our cancer rates are on the rise. And burden also, it is on the, thereby burden also on the rise. So in fact, the strategies for cancer control, geriatric oncology services will be very useful. Then second, and another important point is, our common cancers, breast cancer common, but stage at we know that if the disease can be detected in the early stage, it is almost curable, more than 90%. But still, our 2/3 of cancers are detected in the third, even in fourth stage also. That is very a sad story. In fact, we need to think of cancer primary prevention programs and providing awareness for detecting the cases. In fact, reporting to a hospital at the earlier, if you see the symptom, without ignoring the symptom, reporting to a hospital, that is very essential. In fact, even among educated people, delay the symptoms and report to hospital late. So thereby stage at diagnosis will be third or fourth, like that. So then we know that the detection, the cure rate is very bad, very poor. So steps are to be taken for detecting reporting cases in the early stage, particularly breast cancer. In fact, our 30% of cancers are breast cancer. So something seriously we need to think of how the disease can be detected in the early stage. Means creating awareness to the society, that is very essential. Then I will share some of my hospital-based cancer registry experience. So we have observed that over the years, the dropout rates are going to be high. It is increasing. So dropout rates and incomplete treatment, for treatment completion, in fact, even early stage, I know that several early stage cases, surgery taken and then they'll go away. So we know that there is, it is almost, the survival will be almost similar without taking any treatment. So that is also very important. So in fact, decentralization will be very useful if people in the nearby location complete treatment, so that their cure rate, the treatment completion will be very high. So that is also another important point, that treatment completion. Then I have noted a few more points. Okay. Okay, these are my thoughts for sharing with you.
Thank you very much. Can I invite Dr. Raman Kutti if you have? Yeah, sure.
Good morning. And I would like to thank the organizers for this opportunity to talk to you. And I think it's a very good idea to get, people of different backgrounds together for an event of this sort. I hope this continues. Unlike most people who talked before me and also people who are in this hall, I'm not directly concerned with cancer treatment. I'm a public health epidemiologist, and that is the perspective I am going to bring. And I have been talking or teaching public health policy for a long time. So I would like to bring a policy perspective on the challenges to cancer containment in Kerala, and that is how I have shaped this short presentation. So as you have seen already, and I'm not going to repeat, Kerala is ahead of all India average in terms of the incidence of cancer, and the leading cancers have already been pointed out is lung in male, mouth and colorectal, and breast cancer in the female. So all those have been delineated. But why we are ahead of the national average is something that we have to think about. On the one hand, as Dr. Eliama pointed out, it might be a detection bias. More people might be getting, but apart from that, there is the obvious reason that we have the oldest population in India. growing population getting older. And that is an important contributor to this problem. But we also have to put it in perspective that cancer incidence in Kerala is lower than the world average, and that is something that we have to understand. And also it is much less than some countries like USA. So that is something which we have to put it in perspective. So what are the types of problems that pose a challenge to our containment policies? I would say there are three groups. One is perception problems, misinformation problems, and financial problems. And what are the perception problems? Now, perception problem starts with the idea among the public that cancer is the most important cause of death in Kerala, which is false. Cardiovascular diseases kill 1 in 4 people in Kerala. Cancer is only about 7 to 8%. But maybe for cancer therapists, it's a good thing that policymakers think cancer is very important. So from that perspective, perhaps we should not be complaining. But the truth is that it is in perspective, cardiovascular death is much greater in Kerala. Second perception problem is that people believe that increasing trend in cancer in Kerala is caused by environmental carcinogens, especially toxins in the vegetables. That is a very common thing that we always get. And repeated surveys by the Agricultural University, they take samples from the market and they look for pesticide residues in the vegetables, and they have found that it is not true. The pesticide residues in the vegetables sold in the market are very, very low. That is what the statistics show. But we still believe, most people still believe that all these carcinogens enter us through the vegetables. And because of that, if you look at the dietary surveys in the all India level, the Kerala diet lacks in fresh vegetables, and which is actually might be a bad thing for cancer, because we don't eat enough vegetables as a population. So that is another perception problem. The third thing that people believe is that cancer is nearly always fatal, which is also wrong, because a lot of cancer can be contained, some can be cured. People can live with it for a long time, so this message has not really gone to the people in a big way. So these are issues which policymakers should look at. Then misinformation on a large scale. Misinformation because, as I said, the reasons for cancer. In fact, there is a neglect of some very serious risk factors like obesity, alcohol, and lack of exercise, which are not really stressed as possible risk factors for cancer. These are not exhibited as possible risk factors for cancer, and people really don't know that alcohol can be a risk factor for cancer. Lack of exercise, obesity can be a risk factor for cancer. And then, of course, lack of awareness of something that they can do, like preventive interventions like vaccination, HPV, hepatitis vaccines. Late diagnosis is another. Many cancers are getting detected late because of various reasons, and basically because the primary care system is not really integrated cancer care into that on a large scale. Of course, there are advanced hospitals, but detection goes on at the primary care level. And then finally, something which we always talk about, but we don't want to discuss, that is the shopping for therapy which happens in the population. They try various kinds of scientific and unscientific kinds of therapy. And by the time they get to the proper treatment, it is too late. So that is also another challenge to containment that comes from the population. And then finally, the financial problems, because lack of access in the primary care level, that is, if you go to the primary care center, you may not be able to detect cancer even if you have a symptom. So that you get referred to another level, and on the way, you drop out. Maybe because you don't have the money to sustain that chain. Then catastrophic treatment charges in many instances. Catastrophic economists define as, they have a very definite definition of catastrophic treatment costs, which is like, basically what it means is that the family has to go into debt to sustain the treatment, which happens all the time with cancer. Inadequate insurance, even in people who have insurance, probably they are under-insured. For many people, it is under-insurance, the big reason for not, like Dr. Eliama suggested, people drop out of treatment halfway because they don't have the money. And for poorer people, it is loss of livelihood. So these are some of the big challenges to cancer containment which policymakers in the state face. And what can we do? There are some solutions which are not maybe the final solutions, but at least something which we can talk about. One is that a comprehensive cancer program which for early detection, intervention, integration into the primary care system, so that people who go for anything gets a cancer checkup after a certain age and the early cancer is picked up. Then campaigns of awareness of risk factors such as obesity, lack of exercise, alcohol, smoking, sedentariness, all those things. Creating a cancer care fund for the poorer people, which may help them to get over their treatment costs. And for the rich people or people with employment and other income sources, they may be encouraged to go for a higher level of insurance to sustain this cancer care costs if at all they get this disease. So these are some of the suggestions. Because lack of time, I'm not going into the details. But these are serious issues, and I think we should be prepared for the future. As I said, our incidence rate now is not as high as USA or many of the other advanced countries. But the way we are, the lifestyle is currently in Kerala, we may reach there sooner rather than later. So we have to be prepared. Thank you.
Thank you, Dr. Kuti, please. So I'll invite questions and comments from the audience, please.
Can I ask one question?
Yes,
before
please.
the audience?
Yes, they can go to the mic. Yeah.
You see, what is important is some observation that gastrointestinal tumors like pancreas, stomach, colorectal, so common. I do not know what happened to the statistics. Is it these are the cancers which are increasing?
Yes, they are. I didn't present the entire spectrum because of the purpose of this session, but even cholangiocarcinoma is very high in Kerala compared to many other parts of the country. And if you look at colorectal, yes, this is the first state to show the rise. So all GI cancers are increasing.
My question is to Dr. Prashant Mathur. Almost all the speakers pointed out the very, very high rise in incidence of thyroid cancer. Is a diagnostic bias? And along with that, my question is that is the mortality proportionally going up? Because you have seen in countries like South Korea and in America, incidence goes up, but the mortality remains flat. What is our story here?
Same story. Incidence is going up, but we don't see so much of mortality, which is...
So overdiagnosis is
well, these are invasive cancers. So these are cancers which are treated by oncologists. Overdiagnosis comes when you pick up a lot of benign tumors and start treating them for benign interventions. So mortality, if you look at South Korean example, mortality rose because of unnecessary surgeries happening. Okay. So these are patients who were invasive thyroid cancers and those who have been treated with anti-cancer directed treatment.
So we need Madhavan Kuti sir type of people to come and say that less than 1 centimeter thyroid we should not investigate and treat.
Yes.
That message should go to the community.
Yes, and I think when you have a session on cancer research priority, this should be a research question which Kerala should take lead in, because this is something, today it is here and there are pockets in Papumpure, Arunachal and all, we are picking up rising thyroids. So this is a very timely intervention which can happen from this place.
Thank you, dear Prashant sir and other panelists. You have all narrated what is the present situation in Kerala. My question is, now we are living in the era of AI. Do we have really any projection for the future? But whatever we are seeing now probably is not going to be the same in the forthcoming future. That's what we all share. Do we have any projections for the future?
Yes, I presented that projected slide for
What exactly
2030.
are the figures we are looking at?
So you are looking at almost 43 to 45,000 new cases being added annually.
Every year?
Yes,
That's
new
going
cases.
to be a huge burden.
Yes.
So my question is, your experience, you all can answer this. This is something which we are all facing when we go to the public. This is really a preventable one. And what advice will you give to the public for making it a preventable thing? These are the steps you should do, because unless you really, concentrate on those things, we are going to get, anybody in this hall can get cancer. That's the way things are going.
Yeah, so almost 60 to 70% cancers in India are preventable. No, preventable doesn't mean that, we can stop it, but we can take measures to curtail their incidence rates. Okay, so whether it is tobacco, alcohol, diet, physical activity, obesity, and the new villain, air pollution. So why is lung cancer increasing in spite of declining tobacco rates, smoking rates? Air pollution, indoor air pollutions are something which we have to challenge very aggressively. So if you look at site-wise, yes, there are cancers so this data should actually be used as a prevention and an advocacy tool to say that these cancers are, you can do a lot about getting those cancers by avoiding the primordial risk factors. These are very well defined.
We can definitely do some intervention, and we have examples in front of us, like the Western population. What they have seen is there is something called the climbing the hill phenomenon. Like they have already reached the top and they have started descending. Similarly, for India government, I think the cancer was not the priority at all for a long time, and they have just started doing the intervention. And in Kerala, we have started at the government level screening first time in the history. So definitely, if you start intervening, then identifying the risk factors specifically for the demographic area, and then start in educating, creating awareness and interventions will definitely reduce the burden. And the mortality is something which we can always control by offering the best form of treatment. I think the Indian national mortality rates are going up. I think so, but the Kerala it is almost stagnant.
So my last question is about, Kerala is probably the population is the only place where you have a different religious groups here. So 50% probably Hindus and 30% Muslims and 20% Christians. So they all follow different diet patterns. They have different habits. Do we have any, because that will give us a lot of insights about, because we are genetically the same, but we are following something different. So as far as the diet and habits are concerned, do we have any insights from our tumor registry data? Do we really record such data?
I think the Eliamma madam has got the RCC, you are having the religion-wise data available. That is what you have published in the website.
In fact, it is a sensitive question. No? Religion-wise, we have, as he mentioned, so religion-wise data publication, it is a sensitive issue because diet plays an important role, particularly non-vegetarian diet. That could be the reason for the increased, particularly red meat consumption, could be the reason for the increased incidence of our colorectal cancers, that is in both gender. So diet plays an important role for colorectal cancers particularly. Then other cancers, in fact, stomach cancer not increase, decline. Diet, in fact, has role, but it is on the declining trend. Esophageal cancers also on the declining trend. Then pancreatic cancers not increasing. So colorectal cancers, in fact, we need to study why diet, the role of diet and indirectly religion.
Thank you.
See, I don't know about cancer statistics, but all diet surveys show consistently that in Kerala there is no much difference between religious groups in the diet. They all lack vegetables, they don't eat vegetables, they all eat red meat. only about 2% of the population consistently in surveys say that they are vegetarian. So this is a consistent finding in all across. I mean, if you take all the states in India, this is an exception, always. So I don't know whether that matters so much.
So I'm Dr. Prasad. My question is almost like a follow-up to Sanju's question. To Professor Ramgati, when you talk, you said that there has been analysis about the vegetables and then the pesticides. So there is not much of to say that this is coming from pesticides. Also, when Dr. Mathur showed the graph, we saw that the maximum increase is happening, or the skyrocketing is the liver cancers, which was very surprising. And we always talk about the non-alcoholic fatty liver being very common. And when you link this and also the incidence of diabetes, when I practice in Bangalore now, but most of my Malayali patients actually, I am also a Malayali, the incidence of diabetes is just unbelievable actually. It is almost rare to find a patient who is not a diabetic. So do you think that there is a relation between our carbohydrate rich diet and these cancers? When you see that there is an increase which is happening in the liver cancer, which is interesting. I didn't know that that is the most fastest increase in cancer from Kerala registry.
Yeah, I mean, I don't know the answer to that question. As Dr. Warrier also said, diabetes is related, so it could be one of the contributory factors to liver cancer.
Yeah, so if you look at NAFLD, now known as MASLD, so the hepatologists say that that is the trigger. So it is not diabetes causing liver disease, it is liver disease causing diabetes. And now MASLD is part of the national NCD program, prevention and control, with the philosophy that you have to protect the liver first, and diabetes is a consequence of that. So they go hand in hand. In fact, as our alcoholic liver disease keeps coming down, this will take over, and this will take over very rapidly, very rapidly. So the entire metabolic syndrome is a big problem. Whether it is liver, whether it is uterine cancer, ovarian cancer, everywhere this is going to play havoc, the metabolic. And yes, we know we are metabolically deranged, genetically as Indians, and then you have the specificities around the states of India. So that is a big challenge. Yes, you will have.
So Dr. Warrier, I know that your passion in organic farming and how you promote that. So what is your comment on this? Because all our patients want us to tell them something about diet, right? So do you actually tell them that organic farming is something which everybody should try?
Thank you for this question. Actually, I always tell them to take more fiber-based diet and less non-vegetarian diet, and I make a lot of controversies in my own hospital. And since I am a pure vegetarian, people think that I'm a proponent of vegetarianism only because I am a vegetarian. But all the panel members have agreed that non-vegetarian diet will definitely contribute towards the thing if consumed in excess. I always tell them that it is in excess. Previously, we used to take only once in a while when any guest comes in our home or in some special occasion. But in Kerala, the transformations, what we have seen is in every day people take 3 times a day at least non-vegetarian diet, meat, and that too red meat. And even people have all the parties have conducted competition of beef eating in Kerala. So this is the kind of transformation we see, and that has definitely contributed. And coming to the organic part, organic vegetables, there is a very large study from France where 50,000 normal population were subjected to study, and what they have observed is organic vegetables are rich in minerals, and that is the reason why they prevent cancer, but not because of the lack of pesticides. So I don't know about the direct relationship with the pesticides, but there are studies which clearly showed the relationship with the multiple myeloma and MDS, at least in the hematological side.
Thanks.
So can we restrict the questions to one question per person so that we are about to start the inaugural function soon also?
I'm from Kerala University, and we are doing research on cancer related aspects. And I found that there will be a well-established population registry is available, and is it can be shared with the research institute for study purpose, and there is any biobank facilities like a research aspect is available in cancer related aspect. And another questions are mentioned about insecticide is very important. There is any studies are actually related to the microplastics and nanoplastics, because the presence is alarming nowadays, and there is any studies are actually happening on this aspect. Thank you.
In fact, primary data, we cannot publish it. We can publish only secondary data, I mean summary data.
And I'm talking about, is it the data is actually shared with research purpose to the universities and other institute doing cancer research?
In fact, we collect, our data collection procedure is active. So in that method itself, we are mentioning that this data will not, the data is kept confidentially. Under that condition, we collect data from various sources. So we cannot share the primary data. In fact, we publish data regularly. That data can be utilized for research purpose. It can be used for public. For research, including research purpose. So summary data, that is published. In fact, nationally it is published. National data is that it's all based on the publications, so that national data, it is all various cancer registry data. We regularly publish annually individual registries, and then summary data published by ICMR.
I think the insecticide one you can discuss with him.
It's not insecticide, there is microplastics and nanoplastics actually.
I think there is a queue behind you. We are running short of time. Sorry. So Dr. Aman Kutty will be available.
Bank facilities available for research activities.
Biobank, who has in Kerala? Maybe RCGB Trivandrum has, I don't know.
I'm Dr. Sridharan, medical oncologist. We all have been talking about the increasing incidence of breast cancer. But what I've been saying over the last 20-25 years is, it's not that breast cancer is increasing, it's the increasing incidence of young breast cancer that is happening in Kerala. So, is there any kind of studies that are taking place, and if at all, who is going to conduct these kind of epidemiological studies to find out why this alarming increase of young breast cancer is happening? And what are your thoughts regarding that?
So I think we leave this for, there is a separate session on cancer research priorities. I think that group can flag this question. So I think we have to end. I thought I would give you another concluding remark.
We have a little bit more time if somebody wants to ask a question. Let me ask a question to you, sir.
So, as organizer, I cannot refuse.
So Kerala has always topped the nation in terms of crime records data, in terms of COVID data. We have always been the bad guys in India. The highest crime, because our NCR crime records data shows high crime. COVID deaths highest in Kerala, COVID diagnosis highest in Kerala. Is the data that you showed, cancer, is also increasing dramatically high. The survival rates are subpar. Some of it, some of it, can it be attributed to the significant data gathering ability from Kerala? Or can it be entirely attributed to Kerala's completeness of the system? And one more question is microscopic verification. Is it any higher in Kerala versus rest of countries, rest of the states in terms of pathology diagnosis? Thank you.
Regarding microscopic verification, we cannot say that we are the highest. So it is almost comparable. So if you take all cancers, 80%, 80 to 85% microscopic cancer diagnosis percentage. Then regarding the, what was the other question? Completeness. Completeness, we in fact, there are quality indicators. So on the basis, what proportion is data completion, quality indicators, mortality, incidence, and when you take the ratio, then another is death certificate only. Those, based on the indicators, we can assess the quality of the registry. Then, what was your third question? No, I thought of answering that question. What was that? I forgot that.
I asked basically two things. One is the NCRP, the National Crime Records COVID data is all looking bad for Kerala. The second one I asked was, I mean, is it Kerala's cancer data is it because we are good at data gathering?
Regarding the publication, in fact, we publish data other than reports. Based on our registry data, we publish a lot of survival data. In fact, national publication is there for breast, cervix, head and neck cancers recently published. So where Kerala stands almost highest survival for breast cancer. In fact, our 5-year survival is highest. Trivandrum and Kollam data published. Then in national publication, you can check the national publication, breast, cervix, uterine cancer, and then for all head and neck cancers and other cancers are in the pipeline.
Yeah, one important point is we have been always, we give so much importance on the quality in everything. Like if you look at the insistence of quality in the various areas, I think Kerala will be number one. And that is the reason why we stress so much on the documentation. The quality cannot be achieved without documentation. So that is the reason why we at least we maintain a good documentation, and that is the reason why people get all the data. And if you document in a proper way, the quality of data will be high, and again that will reflect on all these things.
But generally I will say, when I showed you the 43 PBCR slide, you are not in the top 5. So there are many parts of the country which are much higher than you. Okay, so you are still not topping there.
So I still think it is all credit to Kerala because they do have, in terms of healthcare, I think it is a model to follow for the rest of the country. I don't know why we keep looking outwards to set models for healthcare for the rest of the country. So I think the transparency and the of collecting data does mean a lot. So why are we seeing so much is not because the rest of the country does not have increased incidences. And to come to the point of pesticides, I always in my awareness lectures to patients keep talking about these things. So when you talk of endosulfan, I am sure you remember what endosulfan did to Kerala. And of course, there were a lot of neurogenic diseases, but then at the same time, there were a lot of, there was an increased incidence of cancer as well. And so if you look at a place like Malwa, which is a place in Punjab, where there is cotton grown, and there also you see that there is a lot of incidence, there's a higher incidence of cancer as compared to the national average, and there also a lot of pesticides are being used. So I don't think we should underrun the existence of these things because regulation is not there. And there are at least over 50 pesticides which have been banned world over, and we continue to use them. So I think, we need to have very, very strong advocacy to address these issues. And like Dr. Varya was saying, now the gut is known to be the second brain. So you cannot really play down the importance of food. What we eat is what we are in a large way. And I think a lot of emphasis has to go on to those areas also. These are just my comments. Thank you.
Thank you very much. I will have to close this session. Thank you very much to all the panelists and to the wonderful audience. Hand it back to the organizers.
Thank you very much, sir. And that was a very interesting and healthy discussion that we had related to the cancer incidences and trends from Kerala.